colleagues. Good evening, colleagues. Thank you very much for joining us today. We know that there's a lot going on, but you've chosen to take this time to join us on this very important day with this very important topic that we are going to be hearing about from Dr. Smith. Before we go any further, let me introduce myself. For those who might be joining us for the first time, I am Dr. Ausin Rikodana. I'm a GP based in Pretoria, and I have a passion for cervical cancer elimination. I am here today in my capacity as a consultant, or what you would call a technical advisor working with FIND, and I will moderate the webinar. This, colleagues, is the 6th in a series of 7 webinars that we are hosting, and we have one more to go next week, Thursday. So please do not miss it. It will be at the same time at 6 on a Thursday, and we will be wrapping up our series. Now, if you are wondering who FIND is, let me just give you a bit of background about who we are. FIND stands for the Foundation for Innovative New Diagnostics and is a global nonprofit that is focused on advancing diagnostic innovation and improving access to affordable, reliable diagnostic services, especially for women and girls in low and middle income countries at the primary care level and within communities. Now, one would want to know why, this series on cervical cancer. Colleagues, we know that cervical cancer is a preventable disease, but Africa and South Africa and other low and middle income countries still experience a very high mortality rates as a result of cervical cancer. And we know that cervical cancer is the most common cause of cancer in women in Africa, where it accounts for 22% of all female cancers. So colleagues, in South Africa, we as FIND work with the national and provincial departments of health, the private sector, and research institutions to expand cervical cancer diagnostics nationwide. We are currently supporting the Department of Health's Mother-Daughter campaign, whose main objectives are to strengthen and expand HPV vaccination program to vaccinate 90% of girls between the ages of 9 and 15. The second objective of the Mother-Daughter campaign is to introduce HPV screening to reach at least 70% of eligible women. The campaign also is aimed at improving treatment and linkage to care, thereby reaching 90% of women with precancerous lesions and linking 90% of women diagnosed with invasive cancer to the next level of care for surgical, chemotherapeutic, or radiation therapy. The last objective of the Mother-Daughter campaign is to develop an electronic data management system to record individual level vaccination data and track and monitor the vaccination program's future impact. So colleagues, as you can see, these objectives are actually in line with the WHO's cervical elimination strategy, the 90-70-90 strategy. So this is what we are doing as FIND, and this series of webinars is part of our support to the Department of Health to actually achieve these objectives. So before we go into more details, colleagues, let me just settle some housekeeping issues. Firstly, during the presentation, only myself and the speaker will be able to unmute. But then at the end of the session, when we go to the question and answer section, we will be unmute you. So please keep your questions on hand. We will attend to them at the end of the talk. Also, colleagues, please post your questions in the Q&A section. We will keep tabs on them and we will respond to them at the end of the talk. Also, ensure that you complete the evaluation form before logging off. We will launch it just before we finish. It's an online form and it's very short. So please let us know how we can make the webinars better, and what else you would like to hear from us. Note also, colleagues, that all registered participants will receive a link to the recording of the session next week. Am I saying it correct, Lamia? All registered participants will receive a link to the recording of the session. And this will be, you will receive the link next week. It is a link to this session of today. So do not worry about screenshotting or maybe writing copious notes. You will have access to this recording. And I'm also happy to announce, colleagues, that next week is our end of this webinar series. We will ensure that everyone who has attended any of the sessions actually has access to all the 7 sessions. So thank you for joining us, colleagues. We will keep to our end of the bargain and ensure that you have access to these important webinars we have hosted in the last 2 months. Lastly, the webinar is accredited for 2 CPD points, and these will be directly submitted to the Health Professions Council. So colleagues, if you have attended 5 webinars, then we will be submitting your name for 10 CPD points to the Health Professions Council. So I hope that settles some of the questions we've been getting on email and some that I've been getting from different participants over the last couple of weeks. So back to the business of today. Today, colleagues, we are joined by Dr. Trudy Smith, who is here to talk to us about the treatment of cervical precancerous lesions. She's going to talk about the options that are available for treatment, and we are excited to have Dr. Trudy with us today. Dr. Trudy is a qualified medical doctor. She qualified in 1988 from VETS, and is a specialist obstetrician and gynecologist. She got that qualification in 96, and she completed her subspecialty in gynecological oncology in 2009. She is a senior lecturer at the University of the Witwatersrand and also works at the West Donald Gordon Medical Center. Dr. Smith has been involved in numerous clinical studies and protocols, as well as international and national reviews. She is a former president of the South African Menopause Society and has been a member of the scientific organizing committee for several conferences, including SASOC, SAMS, and Continence Association of South Africa. She has also been involved in the supervision of GMP 3 and 4 students projects. She's been involved in clinical teaching, postgraduate teaching, register training, and she supervises registers MED projects and serves as an external examiner at undergrad level and for postgraduate examinations. Dr. Smith has given numerous lectures locally and internationally, and she speaks on radio and television, and is also very involved in cervical screening through the Community Outreach Project. She has over 18 research publications and currently runs an academic outpatient colposcopy unit with her colleague, Dr. Judy Carter, and has attended several courses with British Colposcopy Society, including spending time at Cardiff University Hospital in 2023 in their colposcopy unit. Colleagues, join me in welcoming Dr. Trudy. We are really honored to have you with us, Dr. Trudy. With that, I hand over to you. Over, Dr. Trudy.
Thank you very much for that extensive introduction, but perhaps my hardest job is being a wife and a mother, rather than all the other things that I've done. But I am so grateful and really, really so privileged to be invited to speak to you today. And I hope I will give you some informative information. So I'm going to start again with a bit of background because I think it's really key. And The importance to the background is that HPV is a very common infection. You've heard all of this before, but I'm going to drum it into your heads because many women get that diagnosis that they are HPV positive, and in our colposcopy clinic, they are already dying of cervical cancer, and they also feel terrible. They feel like they've got an STD or something, or their husbands or partners have been naughty. But really, for us to appreciate that it's incredibly common. 80% of women will acquire an HPV infection in their lifetime, but the vast majority will clear it. And it's this word of persistence that is important. And obviously, the older we get, we know that our immune systems are not that great, and we are much less likely to clear infections than the young adolescents and young 20-year-olds. And that the cumulative risk of acquiring an HPV infection from one sexual partner is 46%. So we need to think of HPV as, the word is ubiquitous. It lives everywhere. You can't avoid it. The only way you can avoid it is to never touch that part of your anatomy, never put anything there, and basically have quite a boring life. But essentially, it is really, really common. And I think it's important for us to not stigmatize HPV. HPV lives everywhere. It's there. We wouldn't care about it. We only care about it because it causes cervical cancer. So how do we get HPV? We know we get it through sexual intercourse. We get it through genital, manual genital, oral genital, anything genital that allows skin-on-skin contact. And that proper use may help reduce the risk, but full protection against an infection is really difficult. I always tell registrars you must put a condom from the top of your head down over your feet and tie it there, and then maybe you won't get an HPV infection. But it's there, it's everywhere, you can't avoid it. And obviously there is mother to child transmission, but that's more for laryngeal papillomatosis or for genital warts, HPV 6 and 11. And the reason why I'm bringing all this up is because I need us just to put in our heads about that HPV and the vaccination of HPV. We need to tell people that it's a cancer vaccine. It's not just a vaccine for cervical cancer. There are many other cancers that are caused by HPV: anal cancer, vulval cancer, vaginal cancer, oropharyngeal cancer. I have a medical school daughter who's just finished her ENT block, and you can't believe how many patients have oropharyngeal HPV cancer. And it's common. You can't avoid it. You just can't avoid it. So we need to be able to manage it. So we need to prevent it, primary prevention, and we need to do secondary prevention. And obviously, from a secondary prevention for gynecologists or practitioners, you don't have to be a gynae to manage it. You can be a trained health practitioner in managing abnormal pap smears. But why it's so important, secondary prevention, is that we have this time span to manage it. We don't go and have a pap smear every 5 minutes. We don't have a pap smear every 6 months. We know that it takes time from the initial incident infection to the development of cancer, takes round about 10 years. You might say, how did we find this out? Well, there was a very interesting experiment that was done, in fact, in New Zealand in 1950s. And what happened in New Zealand is they did not believe that pap smear abnormalities resulted in cancer. And they watched women. And it's a very unethical study, but it gave us the knowledge to know that there is this prolonged time from the time of infection to the time of development of cancer. And we also know that if you have a low-grade lesion, in other words, you have infection of just the lower third of the skin, is that the vast majority, 70% of these, will get better or disappear on their own. But there are a group of women that are susceptible, and that is particularly our HIV positive patients and our patients on immune suppressants. These days, we're using a lot of immune suppressants, particularly in our patients with autoimmune disorders like rheumatoid arthritis, like our lupus patients, like our patients who are transplant patients. They're all put on these drugs called biologics or immune suppressants. And when you're on an immune suppressant, your own immune system doesn't allow you to get rid of the HPV, and therefore you get persistence of HPV. Remember, I told you it's all about persistence. So the progression is when you have a normal cytology, and then basically you infect the lower third, and that is what we call a low-grade lesion. And when 2/3 to 3/3 of the skin of the cervix is involved, we call that a high-grade lesion. So it's much more difficult to get rid of a high-grade lesion, and those are the ones we want to treat. And because if we remove the high-grade lesions, we're not going to develop an invasive cancer. And that's what secondary prevention is about. Secondary prevention is the treatment of already infected cells in order to prevent a cervical cancer. So what do we know about cervical cancer? We know that many women are infected with HPV, and then only a few will develop a low-grade lesion. And then only a few of those will develop a high-grade lesion. And we know that probably 70% of high-grade lesions will end up in a cervical cancer. That's why we don't leave high-grade lesions. That's why we need to treat them. But we could theoretically watch low-grade lesions if we were sure they were low-grade lesions, and if we were sure the person was going to come back. That is our biggest problem in under-resourced, underdeveloped areas, is that it's difficult for patients to come back, possibly for many reasons, financial reasons, access to healthcare, etc. And that's why we're perhaps a little more aggressive with our secondary prevention in middle and low income countries compared to high income countries. So what about the old pap smear? So it's very hard for us to have this mind shift away from pap smears to primary HPV screening. So if you look at a pap smear has many problems. First of all, you have to find the cervix. You know how difficult that can be sometimes. You have to have a light to look in the vagina. You have to then put a brush or an adequate thing into the cervix and rotate it. You then have to put it in a medium. So this all requires a human. It then needs to be transported to a laboratory. In the laboratory, it needs to be looked at by a human. And we know when humans are involved, sorry folks, when humans are involved, there's always error. And we've got good data to say a pap smear can be inaccurate 40% of the time. So in other words, a pap smear can say, this is normal. But in fact, 40% of the time, it actually isn't normal. So that's why we're moving to primary HPV testing. HPV DNA is either a yes or no question. You either have HPV or you don't have HPV. The incidence of having a false positive is very, very low. The incidence of having a false negative is round about 5%. That's why there's a worldwide move to primary HPV testing. So we looked at our low-grade pap smears and we said, okay, of our low-grade pap smears, what are the HPVs involved? And you'll see predominantly 52, type 35, type 16, 51, 18. But then we looked at our high-grade pap smears, and you see now how the 16 is starting to move up. In other words, HPV 16 hangs around for a long time. And in South Africa, we also worry about HPV 35. And then when you look at the cancers, look at this, 16 and 18 predominate, then HPV 33 and 35, and then the other high-risk types become less common. So that's why for us as a gynae oncology fraternity, we are anxious about the HPV 16 and 18, because those are the two HPVs that account for nearly 70% of cervical cancers. And those are the two that are sneaky, and those are the two that hang around the longest. I always tell them, tell patients that 16 and 18 is like a bad rash. You just really struggle to get rid of it with your own immune system. So we know that cervical cancer affects this predominant group of women in a bell curve, the 30 basically to 65-year-old women. So those are the women we need to concentrate on before they get their cervical cancer. So the difference between primary and secondary prevention basically is that, sorry, I need to just kill this. The difference between primary and secondary prevention of cervical cancer is when you do primary prevention, that is preventing the onset of disease by high-risk factors. In other words, preventing HPV infection. It prevents cervical cancer from forming, and the way to do that is with vaccination. Whereas secondary prevention is to treat and detect disease in its early stage so that you don't get cancer. In other words, to treat and manage precancerous lesions, a precancer, not a cancer, but a precancer. And cervical cancer has that long lag period, and that's why it's such an attractive thing. And we can, together, prevent nearly 100% of cervical cancers. So what's the natural history of a SIN1 or a low-grade lesion? Well, at 6 months, we know that 49% will regress to negative. 35% of them will stay, and 7% of them will progress to high-grade lesions. So that's why it has always become safe to watch patients with low-grade lesions, that patients with persistent SIN1 lesions, those are the ones that we have to worry about, because those are the ones that are going to end up with a high-grade lesion. So the natural history, obviously, of the SIN2 and 3 is that we do estimate some of them will regress. 30% or so will regress, but the majority will progress into a cancer if untreated. So this is the group of women we definitely do not want to watch. So if you have a high-grade lesion or a SIN2 or 3, those definitely need management. So the South African guidelines, recently we got together and we published the South African new guidelines because we felt that we needed to move towards primary HPV testing. And what our guidelines suggested is that all women from 25 years and older should have a primary HPV test and ideally get it every 5 to 10 years. So I don't know if you remember, in the old guidelines, we said anybody who was HIV positive should have a screening test. Now, what happens if you become HIV positive at the age of 15? It would be ridiculous to screen a 15-year-old. So that's why we changed it so that it didn't differentiate between HIV positive or negative. We want all women at the age of 25 to have primary HPV screening. If you are HPV negative, you will not develop, that is high risk negative, you will not develop a lesion within the next 5 years. And so if you're negative, your next screening can be in 5 years' time. Then what we thought is that if you are HPV 16 and 18 positive, and in some data it suggests even 45, we want those women to go directly to colposcopy. You can biopsy them, but we would prefer, particularly in under-resourced areas, that these women go directly and have treatment from a colpo perspective. And if you are other high-risk positive, it would depend on whether you are HIV positive or negative. If you are HPV negative, it means that this is going to persist. And that's why we would refer those directly to colposcopy. But we felt that if you were less than 40 years of age and HIV positive, that we would do reflex cytology. And the reason for this, we thought, is that HIV positive women, we know, have many, many kinds of HPV types. And those HPV types can come and go. But if they are high grade on a pap smear, they need to be treated. If they are low grade, they could have a follow-up in a year. And if it's still there, then consider treatment. And those were the guidelines that we published in 2023. If you look at the provincial and district guidelines on HPV management, they differ slightly compared to what we had proposed in our publication in 2023. So what we say is that you get an HPV. If you are high-risk HPV positive, you should have reflex cytology. Our slight worry with this is we are now using a super sensitive test, which is the HPV test, and we are adding an insensitive test to it. But nevertheless, you will see that everybody with a high-grade lesion must go directly for treatment. Those with a low-grade lesion, you can thermoablate from a treatment perspective, and those with a normal cytology need to have a repeat HPV in a year. So at the treatment visit, we prefer a see and treat. In other words, we prefer to apply acetic acid or Lugol's, and then decide how we're going to treat them. If we can see the whole squamocolumnar junction, and I'll show you what that is, and the lesion covers less than 2/3 of the cervix, or there is no LETs available, then you can do ablative therapy. So ablative therapy is either with cryotherapy or with what we call cold coagulation, which is actually a thermoablator. It's not cold at all. But if there is a suspicion for invasion, or you cannot see the entire squamocolumnar junction, or the lesion is large, then the person must have a LETs. And the LETs stands for large loop excision of the transformation zone. And we do this because we want to send it for histology. We want somebody to look under the microscope and say to us, yes, this is a cancer. No, this is not a cancer. Our margins are clear or they aren't clear. If it's confusing for you, what do I do with this person? I don't know how to manage this person. You know, there's an app for everything in life. There are no South African apps, but to give you a rough guidance, you can always download the American Society of Colposcopy and Pathology app or the British Society of Colposcopy and Cytology app, and they can give you some guidance if you are absolutely not sure. But I do think that the department's flow diagram is very simple and very easy to look at and manage. And maybe laminate it and put it up somewhere so that you can think, do I treat this one? Don't I? What must I do? Must I bring them back? Mustn't I bring them back? I want to just add this because this is my dream, my absolute dream. And my dream is that we should be vaccinating patients with CIN lesions. And you must say to me, but that doesn't make sense, Trudy. The vaccination prevents, it's primary prevention. It prevents that woman from ever getting an HPV infection and letting it integrate in the cells. But in fact, they have done a study and they've done a meta-analysis of 6 studies. And what they did is they HPV vaccinated unvaccinated patients with a SIN2 lesion. They then treated them. And what they found was the risk of recurrence is much lower in those women that were vaccinated compared to those that had excision alone. So my dream is if we could vaccinate these women, and we can vaccinate, in fact, the vaccine in South Africa is licensed until you're 100 years. It's got no age limit on it. Because for me, the biggest worry is we treat women, and then how do we prevent them from getting the disease back? How do we prevent them from getting HPV back from their partners or from a new partner? And the dream would be that we could vaccinate these women. The second dream I would have is that I have vaccinated myself. And the reason for that is we know that smoke generated from excisional or ablative procedures can expose healthcare workers to HPV. We don't have hard evidence of this, but they are at increased risk of developing HPV infections, particularly in the nose and the upper oropharyngeal areas. And in fact, the American Colposcopy and Cervical Pathology Society suggests that healthcare workers should receive the HPV vaccine if they're not already vaccinated. So, in fact, Dr. Carter and I have revaccinated ourselves with Gardasil 9, and we are due to get our last dose next week. So this is another dream of mine, still a dream. So now we've got a patient. She has an abnormality. We're going to refer her to the colposcopy unit so that she can have treatment. And the picture up in the corner is our colposcopy unit. We were fortunate enough to visit a unit in Germany, and we found this very sexy bed, which is comfortable for patients, but it is not a necessity. There are many kinds of colposcopes that you can use. You can use a unilocular one that goes onto your phone. You can use a binocular one. That's the one that we use. And there are various ways that you can manage patients. In South Africa, in the private sector, there are still many practitioners that take patients to theatre. And that is really not necessary. Colposcopy is an outpatient procedure. So we have to appreciate this concept of the squamocolumnar junction. And the squamocolumnar junction is that junction that is between the tough squamous skin from your vagina that joins the delicate columnar epithelium of your endometrium. Now, before you became a reproductive woman, the squamocolumnar junction was deep and high up in the cervix. And then as you got estrogen and progesterone, your squamocolumnar junction comes to lie on the outside. And when it gets exposed to the acid of the vagina, you get what we call the transformation zone. So that's where the old squamocolumnar junction was, and the squamous epithelium starts growing over it, and you get the new formation of the transformation zone or the new squamocolumnar junction. And that area is called the transformation zone. Often in the transformation zone, you see little Nabathian follicles, you can see gland openings, and this is where the squamous epithelium starts to go and cover over the columnar epithelium. That's a simplified version. But if you think about it, often some women have what we call ectopy. That's where the columnar epithelium is exposed to the vagina, and those women can get like a mucousy discharge. And that's because the squamous epithelium, or their transformation zone, is way out on the outside. So we like to, in colposcopy, describe the transformation zone as 3 types. And the reason for this is that you must be able to see that whole transformation zone. You want to see the new squamocolumnar junction and where the old one is, in order to adequately treat something, because that's where the HPV lives. I always explain to patients, I tell them, you know, when you have plumbing and you join 2 pipes, if it's going to leak, it's going to leak where the join is. And the HPV, it loves where the join is. It loves the squamocolumnar junction. So you have to see the entire area if you're going to do adequate treatment. A type 2 transformation zone is when you can partially see it, it's partially visible, but you need to open the cervix and have a look inside in order to see the entire area, and in order for you to reach it if you're going to use an ablative probe. Whereas a type 3 is when your squamocolumnar junction is not fully visualized and it's deep up in the cervix. And that's very common in older women. So in postmenopausal women, the squamocolumnar junction is often up in the endocervix. And that is where particularly HPV type 18 loves. It loves the endocervix. So this is a patient of ours. You can see we put acetic acid on. This is what we call the transformation zone. That white area on the outside was the original squamocolumnar junction. This is the new squamocolumnar junction. And this is the transformation zone where we've got an aceto-white lesion. So this is the acetic acid, 3 to 5% that you put on. And then obviously you can use Lugol's iodine, and that demarcates the area up so beautifully for you to see and where you need to treat. So this would be what we would call a type 1 squamocolumnar junction. This one we can't see. We can't see the squamocolumnar junction totally. We can see the transformation zone. We see some of the squamocolumnar junction. We need to try and get in there. So we would have called this a type 2. But when we opened it up, we could see the entire new squamocolumnar junction. And when we put acetic acid, the Lugol's iodine, we can see where our lesion is, and we're able to demarcate the entire area that we would need to treat. So now we have a woman who is screened positive for a high-risk HPV, and we need to treat her. And we need to decide, are we going to do ablative treatment, or are we going to do a LETS? And I've told you the squamocolumnar junction is very important. So if you have a type 1 or a type 2, you can see the entire thing either easily or by using some form of, we usually use an endocervical speculum to look all the way around. Then you are able to use thermal ablation or cryotherapy for treatment. But if you can't, then you must use a LETS. So what makes somebody eligible for thermal ablation or cryotherapy? The whole transformation zone must be seen. It can be a type 1 or a type 2, but you need to completely ablate that squamocolumnar junction. In other words, the tip that you are using must be able to go in and cover that whole squamocolumnar junction. That's what makes somebody eligible for an ablative therapy. So let's start with thermal ablation. It's often also called cold coagulation. I have no idea why, because this little tip here, the heating tip, heats up to round about 100 degrees. You can choose various tip sizes according to the size of the area that you need to ablate. The heated probe is applied directly on the abnormal area of the cervix. You place it on the tissue for around 20 to 40 seconds of the treatment area until you can see it goes white and is sufficiently destroyed. And then what you do is this high temperature will go on for around about 30 to 40 seconds. You press a button. If it's not destroyed, you can reapply it to the area that you're going to treat. You can see this is portable. There is a battery component that you can charge and lasts for a long time. So this makes it very attractive to use in an area where you've got intermittent electricity or that you need to portably transport it and manage patients. These tips can be sterilized. They can essentially be put into Sidex, which is not ideal, by the way. There's good data now to suggest the only way to kill HPV is either by boiling or by autoclaving or hydrogen peroxide, in fact, but I do know many people use Sidex. So what do you tell a patient that you're going to thermoablate? So the aftercare is that they can return to normal activities on the same day. Our patients do not get 3 or 4 days off work. We tell them it's illegal, that they can return to work the next day. They might experience some mild discomfort and cramping. You can have a watery or bloody discharge from the cervix. They must avoid sexual activity or putting anything in the vagina. We like 4 weeks to allow for proper healing. Because if you have intercourse too early, basically you disrupt the scar and you increase that person's risk to acquiring an infection. So preferably 4 weeks of nothing in the vagina, no tampon, no douching. We prefer patients to shower, to not bath, and to not swim. Is it effective? Well, we certainly know that thermoablation is highly effective for low to mid-grade lesions. In other words, for SIN 1 and SIN 2, its efficacy is between 85 and 95%. And that a follow-up visit, we don't pap smear patients. The follow-up visit needs to be an HPV test because the HPV test will give you the point of cure. Because if the HPV is gone, then it means that you have been cured. What about cryotherapy? So cryotherapy requires a cryogun with a cylinder with either carbon dioxide or nitrous oxide. And this cylinder can often be large. You do get small tanks of coolant, but this is much more cumbersome than the thermoablator. And in fact, we really are moving probably away from a cryogun towards thermoablation. So what happens here is the probe delivers liquid nitrogen or carbon dioxide gas at a very low temperature, and it freezes the cervix and it freezes the cells. And by freezing the cells, you destroy them, and you do 2 cycles of between 3 and 5 minutes each. So in fact, it's a much longer process than the thermoablator. And you have to sit there and hold it against the cervix for that period of time. What happens is it causes ice crystals to form in the abnormal cells, and these cells die and over time are replaced and become basically, you destroy that area. You get a watery discharge for 2 to 4 weeks. You can return to activity straight away. And again, you should avoid sexual intercourse, anything in the vagina, and allow that to heal properly before you put anything in there whatsoever. The side effects, you can get mild cramping and discomfort and this watery discharge. Some of the rare complications include an infection, heavy bleeding, and scarring of the cervix. And the scarring can result in a very tightly stenosed cervix with blood backing up or a hematoculpus behind it. It is an uncommon complication, but certainly can occur. If you look at the effectiveness of cryotherapy, you'll see that it is slightly less than thermoablation. So cryotherapy is around about 85 to 90% in SIN 1 and SIN 2 lesions. And again, your follow-up should be for these patients primary HPV testing because by destroying the HPV infected cells, you would presume you've destroyed and got rid of the HPV infection, and that that would be a test of cure. The disadvantages are, however, that it's not suitable for very big areas. You can't freeze big areas, and you should not be freezing high-grade lesions. The other disadvantage is you've got no tissue to say that you've removed the entire area or that there wasn't a malignancy in there. And so those are the disadvantages of ablative therapies. But nevertheless, they are highly effective and they are cheap and easy to manage. Obviously, there's a risk of incomplete treatment, and you might need to go back and do another treatment. But I want you to appreciate that you need to see the entire squamocolumnar junction in order to do ablative therapy, and that cryotherapy is not recommended for women with large lesions or high-grade lesions, and none of them are appropriate for pregnant women or in anybody with an active pelvic infection. If we were to compare the two, remember the thermoablator or cold coagulator, which isn't cold at all, uses heat, whereas the cryotherapy uses cold. The duration of the procedure is the same. The thermoablator is a little bit better than the cryotherapy. The cost is basically low for both, but the tips on the thermoablator are reusable, whereas in the cryotherapy, you require a gas canister, which needs to be refilled in order for you to perform the procedure. The equipment we know, I've shown you pictures of that. In terms of anesthesia, you do not require an anesthetic. We do personally prefer to do local infiltration into the cervix when we treat patients with our thermoablator. The side effects are the same. They are suitably equal. But again, no tissue sample for pathology. That is the disadvantage of these treatments. So what about a LETS procedure? And I want us just to think about the complications of a LETS procedure. So we know that women who have had a large LETS procedure, 14% of them can have premature births. And in other words, delivery before 37 weeks. It does not stop you from falling pregnant, but it does put you at risk, particularly if you are doing a very large LETS procedure, of delivering prematurely. And we know that premature rupture of membranes go with premature delivery. And the need for cerclage occurs in about 11% of women who have a large LETS. I can't even remember when I last did a cold knife cone. A cold knife cone has a much higher incidence of premature delivery. And in fact, we know that a LETS procedure is probably a better procedure than a cold knife cone. So LETS procedures. Unfortunately, a LETS procedure requires electricity, and it requires equipment, and it requires disposables. So here you use a thin electrified loop of wire that basically excises the transformation zone. The loop cuts away as it cauterizes when you use a special machine, and that tissue can be sent off to the pathology lab. And the advantage of that is it can tell you whether your margin is clear or not, and it can also tell you if there is a microinvasive carcinoma or whether there is a carcinoma within your specimen. Unfortunately, it requires skill, it requires training, and it has a higher complication rate because you can, if you are not careful, cut and damage the bladder in the front and the rectum behind and cause thermal injuries. The recovery is the same. Most women return to normal activity the next day. You do get a much more bloody discharge than you do from the thermoablation. We tell our patients they can bleed up to 6 weeks. Generally, the bleeding occurs maximally 2 weeks after the procedure, and that's when the eschar or the scar is starting to heal. And again, no intercourse, nothing in the vagina, no douching, preferably showering, no swimming for 4 to 6 weeks after the procedure. If you're looking at effectiveness, it is a much more effective procedure, particularly for your high-grade lesions. It's about 90 to 95%, and it also allows you to know whether your margins are clear. So when we do, and I'll show you a picture, when we've removed that section with the LETS procedure, we use a roller ball to cauterize the edges. And even if your margins are not clear, if you've done an adequate cautery, often that mops up the leftover cells. But you will only know your point of cure is when you repeat your HPV test. The advantages I've said is the tissue sample. It's effective for larger lesions. It has a dual purpose in both that it's diagnostic and therapeutic, and the recovery is quick. So it is a very attractive procedure, but it costs far more to do. You need disposables, you need dithermy pads, you need a dithermy pencil, you need loops, you need roller balls, you need electricity. So it really is, unfortunately, requires a lot more financial investment if you're going to do a LETS. The disadvantage is that you can, like I said, do your cryotherapy and you can do thermal ablation without anesthetic. We don't, but certainly if you're going to do a LETS procedure, you have to use local. We use a dental syringe with lignocaine and adrenaline. And we do a paracervical block, or we inject in 4 quadrants. Generally, we only use 1 vial and it's adequate. In fact, the cervix has very few pain receptors, so it doesn't require a lot of anesthetics. It's a much more invasive therapy than cryotherapy and thermal ablation, and your recovery time to return to intercourse is slightly longer at 6 weeks, whereas the WHO says you can go back to having intercourse after 4 weeks if you use a thermoablative procedure. Essentially, a LETS is an essential procedure, though, in managing cervical dysplasia. In high-grade lesions or in lesions that you are worried about a malignancy, you really should be doing LETS and not an ablative treatment. So you can't say that LETS has no role. LETS has a massive role, particularly in high-grade lesions, and if you're afraid there might be microinvasion. So this is a patient that we had. You can see the aceto-white here. It is not well demonstrated when you used acetic acid. And that's what the advantage of putting Lugol's iodine, if you can't see the entire lesion properly with your 3 to 5% acetic acid, then with application of Lugol's, you can see the area that you need to remove quite adequately. Here we've done the LETS procedure and we've cauterized around the edges and cauterized the base. And this is where we say to patients, if our margins are not clear, hopefully by cauterizing this area, we would have ablated the area that we see. But I must say, looking at our data at the moment, we seem to be pretty good on making sure our margins are clear. So I think in conclusion, we need to say that by working together to prioritize secondary prevention, we can make cervical cancer a preventable and controllable disease in the future. And that if we motivate healthcare workers and public health advocates to promote cancer screening in their practices and communities, we have to get those women to the next step. So the public health department did a very elegant study, and unfortunately, many women have had cervical screening, but less than 5% of those within our Gauteng area who had abnormalities, 5% of those women with abnormalities ended up in a colposcopy clinic or getting adequate treatment. So it's fine to screen, but if you don't follow through with your secondary prevention, you are wasting your time at screening women for cervical cancer. So we really need to be advocates on, yes, my dear, you had your screen. Please come back for your result. Or we must be following up. You know, women unfortunately change their telephone numbers all the time. And it's really difficult for some women to come back. If we could have a single one-shop stop, we screen you for HPV, you immediately get your result, you're high risk positive, you go directly into the Colpo unit clinic, we treat you, that for me would be the dream and the ideal. Because for patients to come back, it's not working. We're not managing to get that right. 5% of women, of those women who had abnormalities, ended up in a colposcopy clinic. And that is a problem. Secondary prevention plays a critical role in decreasing the incidence of cervical cancer. We are not there yet where we have vaccinated every girl and that we have eradicated cervical cancer. If we can get the 90, 70, 90% right, I think that would be the dream. For me, the dream is to vaccinate every girl and boy, make it gender neutral. Ladies and gentlemen, we can eradicate this highly preventable disease. We should not be seeing cervical cancer. Cervical cancer should be a rarity, and unfortunately, it's not. Thank you. Are you there? Can anybody hear me? Can I answer some questions? So I don't know if RC is on the call, but somebody wrote here that HPV tests are too costly in the private sector. So in fact, in Natal, they've moved to primary HPV testing. And if I'm not mistaken, the Western Cape has moved to primary HPV testing. So I think the prices have significantly decreased. Another person asked, but our millennials are HIV positive and very sexually active. Why do we leave them out? We're not leaving them out. What we're saying is that everybody must be screened, HIV positive and HIV negative. All women at 25 must get a screening, and all women must be treated. So, ideally, we should vaccinate all young girls and boys if we could, and then screen them from 25. And if they have an abnormality, whether they're HIV positive or negative, they need to be treated. Yeah, another question. Are males as well, are they eligible for vaccination? Well, in fact, around the world, everywhere, males are eligible for vaccination. So the vaccine is a gender neutral vaccine, but when you've got limited resources, you want to vaccinate the people that are most affected. And those people that are most affected are women. And that's why they started vaccinating young girls. But in an ideal world, we would like to vaccinate both men and women, because men get penile cancer, anal cancer, throat and oropharyngeal cancer from HPV, and women get obviously cervix, vulva, vagina, oropharyngeal, and anal cancers. So ideally, if we had lots of mula, we would like to make it a gender neutral cancer vaccine. So is there data supporting the vaccination of women above the age of 30? Basically, what they have found is that yes, you can vaccinate women over the age of 30. It would be on an individual basis. If you are looking from a national program, obviously young girls must come first, then ideally a gender neutral. And if we had all the mullah in the world, I always say to patients, if you're entering into a new relationship, you should consider getting yourself vaccinated if you weren't vaccinated. You do not have to do an HPV test prior to vaccination. What you need to counsel the person is that if they are HPV positive, then that vaccine will not treat what they currently have got. Then there's a question here. We were taught to insert metronidazole cream in the vagina after a LETS. Well, we use we do use, we actually use fluomycin in the vagina after a LETS. If you look at European international guidelines, they use nothing, but we have a much higher incidence of bacterial vaginosis, etc. So yes, we do put metronidazole cream or fluomycin in the vagina from the next day, and we use it for 5 to 6 days.
Sorry, Trudy.
Yes.
Good evening. It's Dr. Mandondo. I'm a district obstetrician and gynecologist who's also
Yes.
working with the FINE team. I also sends an apology. Where she is, the lights went off, and
Oh,
it looks like they're struggling to get back the electricity so that
no
she can
problem.
reconnect. She's trying to reconnect, so she asked me, after we've done all the questions in the chat, I can moderate the questions. I think they will unmute people when you finished with the questions on the chat. Thank you very
Can you
much.
hear the questions? I mean, you can hear me with the questions, eh?
No, yes, I can hear you.
Oh.
The talk was excellent. You can finish doing the ones in the chat, and then
Okay,
I
and
think
then
the
we'll
rest
do
of
the
the guests
others.
are still muted. So
Okay.
I want to ask the team to unmute the other guests, not just me, to unmute all the other guests, so that then we'll moderate their hands and help me to moderate their hands. Once the questions are up, people are raising hands. Thank you very much.
So I'll continue answering these questions. So the next question is, what other test or screening that can be done to detect HPV, maybe besides a pap smear? So an HPV test does not require a pap smear. So you can do it by doing a pap smear with liquid-based pap smear, not on a slide. So you can do it on a liquid-based pap smear, but you can use a dry swab to detect HPV, and there is self-testing for HPV with a tampon. So you don't have to see the cervix. That's the advantage of an HPV test. You don't need a light. You don't need to stick something in the cervix. You just need a dry swab if you want to do HPV typing. You can self-test for HPV, or you can test for HPV on the liquid in a liquid-based pap smear. So the next question is, please tell me why doctors are not testing for HPV with their pap smear. Well, you know, the bottom line is that it comes to, you know, it's very difficult to change the mindset of people because we grew up with a pap smear. We didn't grow up with an HPV test. But I need to tell you that an HPV test is a much better test than a pap smear. A pap smear has so many problems to it, but it was the best that we had, and it saved many, many lives. But we need to move on to an HPV test as the primary test. So many years ago, when you got your first cell phone, it was a brick and you put up the aerial. Now we've moved to a phone that does absolutely everything. The same happens in cervical screening. We need to move away from primary cytology to primary HPV testing. I don't do cytology at all. I do primary HPV testing. We have done, for instance, in the private sector, a lot of work with the medical aids. We tell the patients, and we have to also educate patients. Patients are like, what's an HPV test? Why aren't you doing a pap smear? Then we have to educate them. It takes 2 minutes to educate them that primary HPV testing is much more sensitive and it's not specific, but it's much more sensitive than pap smears. So the question is, when should we repeat the pap smear after a LETS? We should not repeat a pap smear after a LETS. We must repeat the HPV test after a LETS. So we don't do pap smears anymore after a LETS procedure. We do an HPV test. So you can repeat your HPV test. We do it in 6 months for a high-grade lesion, 1 year for a low-grade lesion, but in fact, 1 year is adequate for repeating your HPV as a test of cure. How often do you follow up patients who are HPV high-risk positive with a normal cytology? So if we have a patient with HPV 16 and 18 positive with normal cytology, they go direct to colposcopy. I can tell you, we have in our trial, so we have not had a single patient who is high risk HPV positive have a negative colposcopy. Not one, not one. And we will publish that data in January. So every patient with a high risk HPV, we have found HPV on their cervix on biopsy. Isn't that interesting? So I can tell you that there will be very few patients with an HPV high risk positive who will have a normal colposcopy. So what we do is in our patients who are high risk HPV positive, colposcopy, we do a biopsy. If they are HPV 16 and 18 positive and we are not going to see them again, they're going to disappear out the system, we would prefer to treat them. If they are non-16, non-18 positive and they have a low-grade lesion on biopsy, we bring them back in a year for another HPV test. There's been studies that have proved that HPV testing alone misses 1 in 5 high-cell cervical cancers, and there are countries that have now returned to co-testing as it increases the sensitivity of the test. Also, it is being investigated that at present shows that messenger RNA is more accurate. So our problem with messenger RNA is that it is a very expensive test and not practical to do. In the studies where they've shown that HPV testing has missed 1 in 5 high cells, is that the HPV test, in fact, was not an adequate test. In other words, somebody didn't put the swab in the vagina adequately, and co-testing would be ideal, but co-testing is very expensive. It is very uncommon to find a high-risk lesion with a negative HPV. So for instance, the US co-tests, but in a low resource setting, it is not practical for us to co-test. We've answered the question on when do you retest for HPV after a LETS. For us in high-grade lesions, we do it in 6 months. But remember, in the private sector, we vaccinate all our patients that we LETS, and we retest them in 6 months, but the national guidelines is in a year. Okay. We've answered the question on when. For patients with persistence in 1 and immunocompromised, is it appropriate to do a LETS? And if immunocompetent, what is the best management? So in patients with a SIN1 lesion that persists and they have high, remember you can have a SIN1 and be low risk HPV. That is never going to turn into a high grade lesion. But if you are a SIN1 lesion and you have a persistent HPV 16 and 18 after a year, we would treat. But if you are non-16, non-18, SIN1, and we see you in a year, we would give you another year. So we would do 2 years, and that's what the ACCP guidelines are, provided you have seen the entire squamocolumnar junction and you have done a biopsy. But remember, if you've got a SIN1 lesion and you want to treat it and you see the whole squamocolumnar junction, it would be better for you to thermoablate that patient because you get less tissue damage. Is HPV test, is it a serum-based test? Definitely not. Remember, HPV does not live in the blood. HPV is a virus that lives on the surface. So there is no serum test. It is a surface test. And there is no HPV test that is validated in males. So you cannot test a man for HPV. There is no validated HPV test. So in the last question, we had a patient in our Colpo clinic referred with a pap smear with no malignant cells, adequate for, but the clinical suspicion biopsy came back squamous carcinoma. Point. This patient, 40% of pap smears are inaccurate. So if this patient had had an HPV test, she would have ended up in a colposcopy clinic. But yes, it is a rarity. And it's unfortunate for that patient, but we have had patients who have a squamous cell carcinoma, but have a negative pap smear. And that's why HPV testing is much more accurate.
Okay, thank you very much, Trudy. This was very informative. I'm gonna pick up on a few things around the males. So if the woman is HPV positive, we're saying you cannot test the male. Is there anything that you should do to the partner in particular, considering that you are also recommending that we vaccinate the woman? Should we do anything to the partner?
So what are you going to do the partner? First of all, there's no validated HPV test for him. You're not going to do a colposcopy on his penis because you can't cut it off. You might want to, but you can't cut it off. There is no treatment for him. The incidence of penile cancer is incredibly low. So there is nothing you can do for the partner. All you can do is ultimately, if you need to, treat the female who has an abnormal pap smear. And then that's why it's not available in the government sector, and we don't vaccinate women in the government sector. But certainly we advocate vaccinating women if they can afford it. But it's very expensive. The problem is the vaccine is very expensive. So we vaccinate all our patients that we're going to let.
Thank you. Can you also clarify, now that you say you are vaccinating the older women, the youth are getting Cervarix. Just clarify the frequency. I'm saying for the audience, the frequency of the Gardasil 9 and maybe the different cost price, because with Cervarix you could do a single dose. And then with Gardasil 9, you were recommending it. So can you comment about that? Thank you.
So Cervarix and Gardasil 4 are the same price. Did you know that? So Cervarix and Gardasil 4 are the same price, and Gardasil 9 is definitely more expensive. So, Gardasil 9 covers 2 for genital warts and 7 for high-risk ones. So, if we've got for instance, if you do primary HPV testing at a Lancet laboratory, they split your HPV into what they call 16, 18, Group A and Group B. And they do that because Gardasil 9 contains 16, 18, 45, and the whole of Group A types. And so, the types, that's like the top 7 types plus 2 HPVs. So, but Gardasil 9 is very expensive. It's 2,500 Rand a shot, and you need 3 shots if you're an adult. Whereas I know Gardasil 9, for instance, in Australia, etc., in somebody less than 14 is single dose. The World Health Organization has recommended single dose, whether you use Cervarix, Gardasil 9, or Gardasil 4 in an adolescent, but in older people, 3 doses.
All right. Providing that clarity. I think that it's been asked a few times that if you are now vaccinating older people, is the 1 dose still effective? So we are clarifying that it is not. We have to do. Now, my second question is, we're 10 years from the vaccinating the youth now. So most of them were 10, 9, 10. Next year, they'll be first years in varsity, so they will be 21. Would you recommend that we would start screening? I know our screening policy is still 30 years to see the impact of this vaccination on the strains they have. Would you recommend screening at 25 for them as well? And also
So
just comment about the booster, please, for them. Do you need a booster?
there's no booster. So the vaccine, there is no booster required. The vaccine has been available since 2008 in the world. So countries such as Scotland, Australia, and the US have been vaccinating since 2008. So I would not advocate screening at 21 at all. We have proposed that screening should begin at 25 and not at 30. That would be the ideal. And we don't know what it's going to look like in terms of screening a vaccinated community, because unfortunately, we have a mixture of vaccinated and unvaccinated. We had a very successful vaccination program, and then COVID hit, and that has fallen behind. So, we need to take into account that we've got a really mixed group of population of women, of young girls. But no booster, no booster.
Okay, thank you, Trudy. Trudy, I'm worried that in this scale up of the cervical cancer elimination, there's too much focus on LETs, colposcopy and LETs, and yet you are presenting to us that thermal ablation is a potential way to go with a learning curve that's shorter and which may assist us with a lot more coverage.
I agree.
What would you do? Have you recommended this? We know that we cannot do the single screen and treat, but would you have recommended this to the Department of Health? Thank you.
So we've definitely discussed it. The Department of Health were within our guidelines that we were proposing. And yes, I think thermal ablation is the way to go. You need to charge up your battery. It lasts 30 hours. We have to train somebody to be able to see the squamocolumnar junction. That's all. And the upscale of it is much, much quicker than, for instance, a LETS procedure. And as you know, LETSs are incredibly expensive because you need disposables.
Thank you very much. Do we have other guests unmuted? Is there anyone who still has a question to ask? All right, it looks like we have covered all the questions. On behalf of AUSI and FIND, we would like to send our sincere appreciation for a very, very informative talk, which has covered a lot of the basics. We are currently in Free State and there's a training for the cervical cancer elimination. And this talk would have worked very well for them because they are still at a phase where the focus is still colposcopy and LETs. So this was very informative. We really appreciate you for your availability to do this talk. And thank you very much.
Available
Before
anytime.
Okay, there's someone who's asking about lesbians. Yes, the question disappeared quickly.
Now, let me answer that question. So, unfortunately, we know from an excellent MED that was done in Cape Town in the population of women who have sex with women, in other words, our gay community are highly neglected. And those women need to be screened exactly the same way as any other woman. And these women are really a neglected group of women. And I would urge that you do not tell women who have sex with women that they do not require screening. That is not true.
Thank you very much, Trudy, for that excellent presentation and answering those questions. I want to appreciate the audience for participating and for attending these webinars. We look forward to seeing you again next week, which is going to be next Thursday, for our last series. And just as a reminder, you will get a recording of this talk sent to your email. Thank you very much. It was excellent. Well done. And good evening.
Have a good evening, everybody.
Thank you. Oh, okay. Sorry, colleagues. In order to get our points, we need to answer the poll. So there is a poll that has been put up. So if you were in the meeting, you are now invited to answer the 5 questions that are being asked on this poll. So please complete the poll before you exit the call. Thank you very much.
Thank you, Dr. Madondo. Colleagues, sincerest apologies. The unthinkable happened, but I'm sure you were in good hands. Thank you so much for joining us, Dr. Madondo. I appreciate you very much. Colleagues, see you next week. Dr. Trudy, thank you for everything. We will wrap up next week. Thank you so much.
Thank you, Elsie. So
Thank you,
the
Elsie, for the
questionnaire-
invitation.
Pleasure, pleasure. So it is then an early good night. So colleagues, see you next week, same time, same place. Good evening.
Good evening. Thank you.